All right, let's dive right in. We're going to simulate one of the most stressful situations for a surgeon, the consultant viva exam. The topic today, the adrenal incidentaloma. This is one of those cases where your answer can really make or break you. So let's get started.
Okay, picture this. You're in the hot seat. The examiner slide a piece of paper across the table. It says, 45-year-old patient, CT scan for unrelated abdominal pain shows an adrenal mass. They look up at you and say, talk us through it. The clock is ticking. So what's the very first thing you say?
The right answer, the one that sets you on the perfect path, is that you start with the basics. A systematic, thorough history, and a focused clinical exam. This is your detective work. You're hunting for clues to figure out if this mass is just a harmless lump or a hormonally active ticking time bomb.
So first up on your list of things to rule out is the most dangerous one, a pheochromocytoma. What are you asking about specifically? You've got to reel off the classic triad: pounding headaches, heart palpitations, and drenching sweats, or diaphoresis. These are the absolute red flags for a catecholamine storm you simply cannot miss.
Okay, what's next? Now you're hunting for signs of too much cortisol. What are the telltale signs of Cushing's syndrome that you'd ask about? Well, you're looking for things like weight gain, especially around the middle, a classic reddened face, maybe some prominent purple stretch marks, and of course, new or worsening high blood pressure or diabetes.
And we can't forget about hyperaldosteronism, or Conn's syndrome. What's the big clue here? It's usually hypertension that's really tough to control with standard medications. But you also have to ask about the effects of low potassium, right? So you're asking about things like muscle weakness, feeling thirsty all the time, or having to urinate a lot. It's all about connecting the hormone to the symptoms.
Now, before you even think about touching the patient, you need to state these 4 things. It sounds basic, but trust me, it scores you major points. You say, I'd gain permission, ensure privacy, make sure there's adequate exposure, and wash my hands. It shows the examiner you're a safe, methodical clinician right from the get-go.
All right, you've done your history, you've done your exam, and a few things are starting to raise some red flags. Now the examiners are leaning in. They want to see your plan. How are you going to get from a suspicion to a rock-solid diagnosis? This is where your investigation plan comes in.
So what's on your list of possibilities? This is your differential diagnosis. You have to be able to list them out clearly. You've got the hormone-producing tumors we've been talking about. You've got the most common finding, which is a non-functional adenoma. And crucially, you've got to include the scary stuff, adrenocortical cancer, or even a metastasis from a cancer somewhere else.
Now, what is the single most important can't-miss principle of your entire workup? This right here. Every single adrenal incidentaloma gets a biochemical workup to check its functional status. I don't care if the patient says they feel perfectly fine. You screen them, period. This is a critical safety net. So how do you do that screening? Well, this table lays out your game plan. If you're worried about a pheo, you're ordering plasma-free metanephrines. If Cushing's is on your mind, the go-to is the overnight 1 milligram dexamethasone suppression test. And for cons, you're looking at the aldosterone to renin ratio. You need to know these first-line tests like the back of your hand.
So let's say one of those screening tests comes back positive. Are you done? Not yet. You have to confirm it. For a suspected pheo, the gold standard confirmation is a 24-hour urine collection for metanephrines. And if the DEXA suppression test is abnormal, your next step is going to be a 24-hour urine-free cortisol to lock in that diagnosis of Cushing's.
Now, the patient already had a CT, but here's a really important point, a common trap. You don't jump to more detailed imaging right away. You use CT or MRI to get a better look at the mass and plan your surgery, but only after you know what it's doing hormonally. So remember the mantra, function first, then anatomy.
Okay, your workup confirms it. It's a 5-centimeter pheochromocytoma. Now we're at a part of the exam where a lot of candidates really stumble. The surgery itself is one thing, but it's the pre-operative medical prep that truly determines if you pass or fail. So how are you going to get this patient ready for the operating room? The first thing you say, and the most critical step, is alpha-blockade. You need to name the drug, phenoxybenzamine, know the starting dose, and explain how you'd titrate it up. The whole point is to block the effects of that massive surge of adrenaline that's going to happen during the operation. This isn't a rush job. It takes a good 10 to 14 days.
But how do you know your blockade is working? You need a specific target. The examiners want to hear numbers. You're aiming for a blood pressure that's consistently less than 130/80 while seated. You have to say that number out loud with confidence.
So once the blood pressure is getting under control, the heart rate often starts to climb. What do? You add a beta blocker. But, and this is a huge but, the timing is everything. You start it only after you've got good alpha blockade, usually a couple of days later. Get that order wrong and you can trigger a hypertensive crisis. Here the target is a nice, calm heart rate of 60 to 70 beats per minute.
Now here's a little something extra to show you're thinking at a higher level. You can briefly compare this intense prep with what you do for another tumor, like one causing Cushing's. For that, the key isn't blockade. It's giving stress-dose steroids before surgery to prevent an adrenal crisis after. It just shows the examiner you've got a broad understanding.
Okay, your patient is perfectly prepped and it's time to head to the OR. Now the focus shifts to your surgical plan. What are the absolute must-dos and the potential dangers you need to have on your checklist for a safe operation?
Once that surgery starts, there are 3 golden rules. 1. You need heavy-duty monitoring, an arterial line, a central line, because the blood pressure is going to be all over the place. 2. You handle that tumor like it's made of glass. Minimal manipulation is key. And 3, the most important surgical step. You find and ligate the main adrenal vein first. That stops the flood of hormones into the body.
And remember, you're not alone in there. You have to talk to your anesthesiologist. There are specific drugs that are absolutely off-limits. Things like fentanyl, ketamine, even morphine can actually poke the bear and cause the tumor to dump catecholamines, creating the very crisis you spent 2 weeks trying to prevent.
Even with perfect prep, the second you touch the tumor, the pressure can spike to 220/120. What's your plan? You need to have short-acting drugs like nitroprusside ready to go. On the flip side, once you've clipped that adrenal vein, the pressure can totally crash. Then the plan is to hit them with fluids and have vasopressors like noradrenaline on standby. And all of this brings us to the main takeaway, the core message for this entire case. When it comes to adrenal surgery, especially for a FIO, it's 90% about the preparation. Meticulous preoperative planning isn't just a part of your plan, it is the plan.
So, the operation's over. You've navigated every step perfectly. The patient is doing well. The examiner is nodding, looking impressed. But just when you think you can breathe, they lean forward and ask one final question, something to really test your depth. Excellent. Now tell me, what are the indications for a cortical-sparing adrenalectomy? It's a tough one, designed to make you think. And we'll leave that one with you to ponder.